We've had two revolutions in healthcare. The first was the public health revolution, an environmental revolution. The second, of the last 50 years, has been the high-tech revolution. And it's been fantastic, astonishing what has happened. Hip replacement, transplantation, chemotherapy, randomized controlled trials, all fantastic. But at the end of 50 years of progress, every society on Earth faces three huge problems. The first is huge, unwarranted variation in access, in quality, in outcome, and in investment. Far greater than can be explained by need. The second, which is revealed by the variation, is the underuse of high-value interventions. For example, even in New Zealand, with a well-organised health service, I'm sure there are hundreds, if not thousands, of strokes could be prevented by the proper management of atrial fibrillation. Then the second problem is revealed by unwanted variation is the overuse of healthcare. Now, overuse is a key issue, and we would never have thought of this, I don't think, until the money ran out. But every society on Earth faces need and demand increasing by about 20% per decade, and no more money. So what are we going to do? Well, we've got to do four things. We've got to carry on doing prevention, evidence-based decision making, quality improvement, and cost reduction. But while we've been doing these four things in the last 20 years, unwanted variation has either developed or persisted or increased. So it's not enough. We've got to focus on value. On outcomes related to resources. Now we can think of value in terms of personal value or population value. And population value is either in the allocation of resources, how much is allocated to cancer or mental health or respiratory disease, how is the cake cut, or value in terms of how the resources are used. Once you've allocated resources to a particular subgroup of the population, people in the last year of life, for example, how are those resources used? Now you'll notice I've used the term invested and the term resource. And we're starting to use the term ROI, return on investment. Some people don't like it. Oh, that's like private industry, they say. But we are investing resources. We're not just spending resources. Now, what do we mean by the word resources? Well, one meaning is obviously, and this is usually the first meaning that comes to mind, is money. But it's probably better to think about opportunity cost rather than just straight money. But money. But what we've done in the last 10 years, and Rachel Stancliffe is going to tell you about it, is that we've taken another interpretation of the word resources. So we also like to think about the environmental resources being used, the carbon, to put it in shorthand terms. And what we find is that frontline staff are often more motivated by an appeal to them to make better use of the resources from an environmental perspective than from a financial perspective. If you go onto a ward and say to staff, oh, this hospital's in financial difficulties, the staff think, well, it doesn't make any difference to us, it won't help us get through to 5 o'clock. And then they say, well, of course it's in financial difficulties, look at the people who are running this hospital, who are often standing beside me. But when you speak to them about carbon, the future, the environment, and climate, then at home, their children are asking about these things. The useful term to use is stewardship. We are the stewards of the planet. We don't own it. We've got to hold it in trust for future generations. Similarly in healthcare, we're the stewards of the health service. If we screw it up, there won't be a health service for everyone in the years to come. So, this is what we've been doing. We set up a Centre for Sustainable Healthcare, and Rachel's going to tell you about how that works. And we're very keen to work with people in other countries who see that there's a need to think about the sustainability of the health service, but also about the sustainability of the environment in which we live.
So Muir's talked about resources and the different ways in which we might think about resources. And value is, as we've heard, a measure of outcomes divided by resources, inputs. And we think of those as people, profit and planet. So people are obvious. We need people to be on this planet, but planet is not always easy to measure. So one of the ways in which we measure the environmental inputs and outputs is by looking at carbon emissions or carbon equivalents. In 2008, the Sustainable Development Unit was set up by the UK government, and one of the things they did early on was to do a carbon footprint of healthcare. This was really useful because it showed that not all of the carbon was in where we might expect it within the system. So you might think that the big hospitals that we have in healthcare are where all the carbon sits. But in fact, only 20% of the carbon is coming from direct energy sources used within hospitals, and the lighting and the heating and all of those big buildings that we have to maintain. Another 15% is from travel within healthcare, and the rest of it, 65%, is from procurement. So that's clinical work that is done within the system. So if we want to tackle the carbon emissions within healthcare, and in the UK we're lucky enough to have the Climate Change Act of 2008, which requires that we reduce our carbon emissions by 80% on 1990 levels by 2050. So that's a huge decrease. If we want to achieve that, we must not only look at the buildings. Now in the UK we're lucky enough to have the Sustainable Development Unit set up within the government, within the NHS, and now jointly held between NHS England and Public Health England, whose job it is to reduce carbon emissions and to look at sustainability within healthcare from within the system. They focus very much on the buildings, and they started by looking at what we can do in terms of waste and heating and lighting and so on within the buildings. When we set up at exactly the same time, the Centre for Sustainable Healthcare decided that it was important to also look at the clinical effects of resource use within the system. So that means engaging with clinical staff and helping them to understand what sustainability means for their specialty within healthcare. It also means working alongside managers and patient groups and so on, other players within the system, but that are involved in the clinical pathways that we see through healthcare, through primary and secondary healthcare. So the Centre for Sustainable Healthcare is helping to achieve that reduction in carbon emissions, and we have four main principles. One is prevention, which is fairly obvious, and it means dragging everything upstream so that all clinical work understands what can be done further upstream to prevent things from getting worse. So Muir's example of strokes earlier on. The second principle is patient-centred care, and that means really thinking about where value sits within the system. So value should always be focused on the patient, and any value which is not bringing value, any interventions which aren't bringing direct value to the patient are not good interventions. And the third principle that we have is lean. So that means cutting out any waste within the system, so things that don't add value at all. They may be historical, they may be political, there may be various reasons for them being there, but they need to be stopped. And the fourth way of looking at this, the fourth principle we have, is of low carbon interventions. So for example, at the moment we're working with an industry group who have a lower carbon syringe. So it's a lighter, smaller syringe which is being used to replace the standard syringes that we've had. So that's an example of an easy change really within the system, which doesn't need everybody engaged but can just be done. So quite often those lower carbon interventions, changes, are reasonably easy to make. They're point changes which don't need a huge system change, and they are the things which get done first. So that might be telemedicine replacing face-to-face meeting, or it might be a different kind of machine that's being used. But those things only get us so far, and if we want to tackle the bulk of emissions within the healthcare system, we need to do those harder things which are about the upstream work. So I think what we found with our work is that both clinicians and patients are very engaged with this agenda. They're very eager to work with us but that we do need some resource which is outside the healthcare system itself probably, which is independent and innovative and is able to bring in the very many different partners that are needed within this transformative change. So I've read with interest the paper from the new administration on climate change policy, and I know that New Zealand are taking this very seriously and want to be world leaders, and I think in order to do that, obviously you have support from within the government. It would be great to set up some kind of centre outside the system which is independent and can help to bring together all the very many different partners that you need in order to help to transform healthcare for a sustainable future.